now we will have to move to our next presentation by it's about pediatric difficult airway. Why is this topic important? I believe everyone who works on the pediatric, our children hospital, will understand why is it, what is the error traps, and why is this topic really important to us. I will leave it to Dr. Kareem Nawwar, one of our most determined, competent, focused, and diligent lecturer in our hospital. So I will leave him to present his lecture now. تفضل يا دكتور كريم.
Thank you, Dr. Maher, for this nice introduction. And I'd like to thank all our professors, our dear professors, for this kind opportunity to share and participate again in this wonderful event sponsored by the Mega Association. Our topic today is about difficult intubation, but from other perspective. It's not just to detect or anticipate which patient could have or anticipated to have a difficult airway to be prepared for. It's also about what to plan other than difficult airway equipments or adjuncts in equipments that most of us or most of our hospitals now have plenty of instruments to aid in difficult airway management. So we will discuss the error traps that we could meet during difficult airway management, especially pediatric airway management. To introduce difficult airway management in children is associated with considerable morbidity. Neonates and children or young infants are vulnerable group for hypoxemia and hypoxic cardiac arrest. Several recent studies have identified multiple tracheal intubation attempts as the most significant factor leading to an increased risk of complications during pediatric difficult airway. Considerations unique to children such as small airway anatomy, decreased oxygen reserve combined with increased oxygen consumption make it essential to have a planned and thoughtful approach to manage the pediatric airway. Multiple cognitive biases were demonstrated to lead to errors in clinical scenarios. Understanding and minimizing these potential factors are essential to avoid preventable complications and optimize the chance of successful tracheal intubation. Our objective in this presentation is to present potential strategies to improve patient safety and to achieve successful tracheal intubation in infants and children with difficult airways. These error traps can be categorized into three categories: the preparation error, performance error, and proficiency error. Preparation error means inadequate planning and communication between the team members. Performance error means unnecessary attempts at tracheal intubation with the same manner or with the same plan. Proficiency error means unfamiliarity with advanced airway techniques and skill degradation. Regarding preparation error, good preparation and anticipation of potential problems are the key to safe airway management. Every clinician attempting airway management must always be fully prepared for the potential of an unanticipated difficult airway, especially in neonates and infants. A recent multi-center observational cohort study, the Neonate Children Study of Anesthesia Practice in Europe, reported a 5.8% incidence of difficult tracheal intubation in neonates and infants, two-thirds of which were not anticipated. While anesthesiologists are used to managing many aspects of patient care in the OR, high acuity emergency situations can be challenging to comprehensively attend to all patient care needs without assistance. For airway management outside the OR, many of these patient care roles are owned by different individuals, leading to incorrect assumptions of workflows and roles, leading to confusion, frustration, and increased risk of complications. Authority bias, which is the predisposition to accept the viewpoint of an authority figure as more credible or more appropriate, can impact how team members process conflicting goals or approaches. For example, the otolaryngologist's main rescue technique may be rigid bronchoscopy, but even if that approach is failing, some anesthesiologists may not feel empowered to take over airway management or suggest moving to another advanced airway technique. Additionally, identifying the individual with the most appropriate airway experience may not always be straightforward. An example of this is an anesthesiology trainee, which may have more experience with airway management in a teenage patient than a pediatric critical care attending. Second, the performance error. The risk of complications during pediatric difficult airway management increases with additional tracheal intubation attempts. In children with difficult airways, direct laryngoscopy has been associated with lower rates of the first attempt and eventual tracheal intubation success compared with other advanced airway techniques. However, anchoring bias, which is known as fixation bias or tunnel vision, may contribute to clinicians not making appropriate adjustments to match the needs of the current situation. Anchoring bias means how we cling to the first piece of information we get. For example, a clinician may approach a potentially difficult airway in the same manner they would in a child without airway concerns, defaulting to a direct laryngoscopy and only considering an advanced airway technique after multiple unsuccessful tracheal intubation attempts. Omission bias, which is the tendency for inaction for fear of being wrong or causing harm, may also prevent the clinician from rapidly considering alternative techniques or taking the next step of a difficult airway algorithm. This comic shows the principle or the meaning of the performance error. This physician is not sure of diagnosis, as we can be not sure of the cause of difficulty of the patient's airway, but he would still treat with the same manner as we use the direct laryngoscopy technique. If there is a perceived hierarchy, authority bias may further reinforce the effect of omission bias. Resistance with failing providers or techniques is a critical performance error determinant to successful airway management. Failure to optimize intubating conditions can further increase the number of attempts at tracheal intubation. Neglecting to utilize passive oxygenation leads to hypoxemia, leading to premature interruption of attempts, which leads to more unnecessary attempts at intubation. Approximately 1.6% of children within the pediatric difficult intubation registry, including 1,289 patients, had a cardiac arrest requiring resuscitation, all of which were preceded by severe hypoxia or hypoxemia. Also, the use of neuromuscular blockade remains controversial in pediatric difficult airway management for the potential of impossible mask ventilation. In the pediatric difficult intubation registry, spontaneously breathing anesthetic techniques were associated with a higher incidence of complications such as hypoxemia or laryngospasm and lower tracheal intubation success rates rather than controlled ventilation techniques. Without neuromuscular block, an inadequate plane of anesthesia leads to increasing the likelihood of airway reactivity with airway manipulation, such as laryngospasm or coughing, while increasing depth of anesthesia will require increasing doses of anesthetic or analgesic agents, which may lead to apnea or cardiovascular depression. In the same analysis, the incidence of impossible mask ventilation, however, was only 0.3%. Third, the category of errors is the proficiency error. As with all technical proficiencies, skill degradation is inevitable if it is not maintained. Relying upon unfamiliar techniques when a difficult airway is encountered may not be adequate for skill acquisition or maintenance. In addition, familiarity with the setup required for the equipment is equally important, which is more significant with the added stress and pressure associated with the difficult airway management. For example, understanding the differences between the flexible fiber optic and the video bronchoscope systems and the unique setup requirements for each, either in or outside the OR, especially if a separate camera head or a light source is needed. Similarly, the use of the non-standard hyperangulated video laryngoscopy requires a different technique to that of both direct laryngoscopy and the standard blade video laryngoscopy, where in the direct laryngoscopy and during using the standard video laryngoscopy, we need to some lifting of the shoulders to obtain alignment of the planes to be able to visualize the laryngeal inlet, while during using the hyperangulated video laryngoscopy, alignment is not mandatory, as the hyperangulated blade curves around the structures, which enables us to see or to visualize the laryngeal inlet without the alignment used in other approaches. Lack of adequate experience with the technique may lead to an anchoring bias, or not initially considering an alternative technique, or not rapidly adapting to changing conditions in the scenario when appropriate. Another relevant cognitive error is overconfidence bias, which is the inability to recognize the need for help or overestimation of one's ability, which is called the Dunning-Kruger effect. For example, not taking over when the trainee is struggling in laryngoscopy, or not considering an otolaryngology fellow or attending when you may have experience with flexible bronchoscopy, or not being receptive to suggestions from colleagues or other clinicians. So we have explored the problems that all of us might meet. So what are the solutions to overcome such problems? The key components of pre-anesthetic planning are awareness of the risk factors and preparation for a potentially difficult airway, even in a seemingly straightforward airway management. Difficult airways may be associated with anatomical features, as we all know, and or physiological factors such as neonatal status, cardiopulmonary reserve, or resuscitation needs, and or airway secretions, or bleeding. Preparation is the key for any plan. During successful execution of an airway plan, initial conversations and clear communication between team members before the patient arrives to the OR, such as requesting help from experienced anesthesia colleagues or involvement of surgical support from otolaryngologists or even the ECMO team. A shared understanding of expectations, knowledge of pediatric difficult airway algorithm, and consideration of environmental constraints such as working in the OR or the ICU or a medical imaging suite. Consistent use of a structured airway timeout or huddle will improve communication both in and outside the OR. A standard checklist or timeout should identify team members and experienced help, assign roles, verify availability and preparation of necessary equipment, and delineate the plan, including next steps if the initial plan is unsuccessful. Good planning and management discussions during anticipated difficult airway cases will facilitate safe airway management for the current patient and promote better teamwork and understanding of roles as well. This is an example of structured difficult airway management timeout, including 4 phases: introduction and roles, approach, ventilation strategies, and airway plans and alternative plans as well. Establishing the routine use of an organized approach as a multidisciplinary timeout will help with effective communication and management of anticipated difficult airways, which is significantly more prone to lapses and errors. The more teams are used to working together and getting familiar with their individual strengths and limitations, the better they will perform in an emergency. During active resuscitation measures, time for formal discussions may be limited, so regular simulations can be an effective way of practicing communication skills and teamwork, especially in unexpected scenarios. Regarding performance error, the rule is to reduce the risk of complications. Every effort should be made to optimize tracheal intubation success with the first attempt. So, first of all, passive oxygenation, which is a simple, underutilized technique. Given the increased liability for hypoxemia in neonates and infants, mitigating rapid desaturation during an intubation attempt may decrease the number of attempts required, as when oxygen saturation is maintained, less time pressure is present, so it thus prevents premature abortion of an intubation attempt. Passive oxygenation may be as simple as low-flow nasal cannula, which is readily available in most clinical settings, or more effectively, a high-flow nasal cannula system. It is not universally practiced as a standard of care, unfortunately, so a change in culture and mindset is needed before its widespread use. Second, advanced airway techniques for the initial approach at tracheal intubation, especially in young infants. Although limited data guides which technique is best for a given patient, traditional direct laryngoscopy is a poor choice due to its very low first attempt and eventual success rates in children with difficult airway. All other studied techniques, including video laryngoscopy with the standard or non-standard hyperangulated blades, flexible bronchoscopy, and combination techniques, had significantly higher tracheal intubation success rates when compared with direct laryngoscopy. An important advantage of a supraglottic airway technique, either for ventilation rescue or to aid in tracheal intubation, is that it may overcome the upper airway obstruction effectively by passing the limitations of face mask ventilation. Given a proven ability to ventilate with a mask or a supraglottic airway, the use of neuromuscular block will optimize intubating conditions. Even with the availability of sugammadex as a reversing agent, the lag time for reversal of neuromuscular blockade must be considered. A recent systematic review and meta-analysis found strong evidence that neuromuscular blocks increase the likelihood of acceptable and excellent intubating conditions and first attempt intubation success in infants and children. It also found a lower incidence of hypotension and cardiac arrhythmias. Neuromuscular block would not be appropriate for conditions known for difficult or impossible mask ventilation, such as mucopolysaccharidosis disorders or large head and neck masses. If there are concerns about the ability to safely ventilate in the setting of a neuromuscular block, a spontaneous breathing technique should be used, but the anesthetic depth, however, must be carefully titrated to avoid activation of airway reflexes before any airway manipulation. Options include high-dose volatile agents plus assisted ventilation, intravenous anesthetic or analgesic agents in boluses immediately prior to actual attempts, adjuncts such as spraying topical local anesthetics over the larynx. Ensuring anesthetic depth of anesthesia during any tracheal attempts. If using a supraglottic airway as a conduit for tracheal intubation in patients who may not tolerate high doses of anesthetic agents, preliminary confirmation of adequate glottic alignment using flexible bronchoscopy may also afford some reassurance to proceed with a neuromuscular blockade. Third aspect, the proficiency error. Approach to solve such a problem should be from a personal and institutional level. Recurring workshops, protocols, and cognitive aids are helpful in establishing a standard of care within anesthesia departments. Individuals should also make a deliberate effort to incorporate advanced techniques in their routine airway management practices to make them less challenging or surrounded by preventable errors. Leaders within anesthetic departments or professional societies need to advocate improving the standards of care. Printed algorithms and visual aids for devices specific to each institution can eliminate reliance on memory for setup and sizing considerations, such as remembering which supraglottic airway will allow the passage of the pilot balloon of a cuffed tracheal tube, or the appropriate bronchoscope sizing for a given tracheal tube size. Awareness of the limitations of different airway management techniques, such as challenging with video laryngoscopy in patients with limited mouth opening or significant micrognathia, or of own's familiarity with different techniques, may help facilitate earlier anticipation in calling for assistance or making a change rather than persisting with a failing technique. Asking for experienced help should be encouraged. Experts within anesthesia departments should be identified as a resource and act as mentors. The concept of departmental airway leads is an example of a successfully implemented process in Austria, New Zealand, and the UK for reducing variability in airway management between clinicians. And actually, it is such approach is practiced in our university, in Cairo University, and especially in pediatric unit. If possible, a system for consistent debriefing after a difficult airway case is an effective way for identifying gaps to help target improvement efforts. Regular departmental case reviews to discuss what went well and what did not go well and why will improve and provide ongoing learning opportunities for clinicians beyond just the technical skills required for successful airway management. And such technique can, this is a summary of the error traps that we have discussed. The overlapping cognitive biases, anchoring bias, authority bias, omission and overconfidence bias, and the proposed solutions which can make management of difficult airway much easier. So to conclude, difficult airway management in children can be very stressful due to the associated technical challenges and risk of complications with increased tracheal intubation attempts. Therefore, efforts should be directed towards recognizing error traps and reducing the number of tracheal intubation attempts. By overcoming such problems by relevant solutions, we can achieve successful, safe airway management and tracheal intubation. Thank you.
Thank you, Dr. Kareem, so much for this very nice presentation. Any questions to Dr. Kareem?
دكتورة مها، دكتور محمد عبد الرؤوف.
دكتور محمد اتفضل.
دكتور كريم، أنا كنت بس عاوز أسأل حضرتك the value of ultrasound in predicting and minimizing the problem of difficult airway in pediatrics.
Nawwar, Dr. Muhammad, you're very welcome to join us in this meeting. The role of ultrasound was discussed in not many literatures, but recent studies have discussed to measure the actual tracheal diameter during choosing the appropriate size of the endotracheal tube. I think it was discussed also for weaning, even after prolonged intubation scenarios, either in the OR or the ICU, to exclude the presence of tracheal submucosal edema or to exclude difficult extubation.
If I can add, Dr. Kareem, to your input about this, كان في رسالة registered for master degree عندنا في الاسم كان أحمد مبروك، وكان he went through I believe more than 100 cases. I don't remember the exact number, but it was a very good الحقيقة to know that the effect of ultrasound أو using the ultrasound الprivilege اللي بيديها for a lot to be measured for predicting airway difficulty. So I can share it with you, but it's a very good one فعلا, very good question. Thank you دكتور محمد.
لو سمحت دكتور كريم، طبعا your lecture يعني more than beautiful. بس حضرتك can we rely on supraglottic devices until you are sure that you have a reliable airway apart from the nasal bronchus? You said so. You said we can rely on nasal bronchus for passive oxygenation.
Yes, to optimize the intubating condition, not for a definitive management.
You can rely on supraglottic, or they have no place.
We can rely, of course, but it depends about the original plan of airway management. If I have no choice that this procedure or this surgery could go with supraglottic airway only or not. We have met a case of difficult intubation, I think 2 to 3 years ago in Aburish, and Dr. Manal Gohari was with us, and we already, the case was a cystic hygroma, a neck mass, a huge neck mass, and it had some degree of difficult mass ventilation. The supraglottic airway device here actually helped us alone, and we could properly ventilate the baby using the supraglottic airway, even without giving a neuromuscular block, or with adding the neuromuscular block. But as the procedure was including airway manipulation or dissection, deep dissection in the neck and beside the trachea and beside the larynx. So risk of complications such as the tracheal tear or pneumothorax was very, very expected. So after we could secure the airway only with the supraglottic airway device, we proceeded with our plan to try for definitive tracheal intubation for the scenario of the surgery.
Thank you, Dr. Kareem.
Thank you, Dr. Azir. Welcome.
Okay, I just would like to thank Dr. Kareem for raising awareness with all these error traps and for trying to change our culture regarding the problems and the solutions for this, for airway management. Thank you, Dr. Kareem.